Hello, this is Joe Bansimer, loss control consultant for Argent. We're a division of West Bend Mutual. Today, as part of the healthcare advisory team, I am going to present to you a webinar on the proper use of a gait belt transfer for the residents and patients that you and your staff serve. So the objectives we're going to cover today are: what are the benefits and the limitation of gait belt transfers, of using a gait belt to conduct a transfer? So we're going to talk in depth about those benefits and those limitations. Are staff using gait belts properly? You know, when you observe your staff, are they doing it the way that you train them, or maybe the way in which you envisioned? And we're going to talk about what makes up a gait belt transfer, a safe gait belt transfer, and what are the injury potentials for your resident, maybe the injury potentials for your staff. What should the resident's capabilities be if you're determining that a gait belt should be used? And what should we be considering for the staff, and not only for your staff, but for your organization, and making sure that throughout your organization, no matter what discipline you might be talking to, maybe it's your therapy staff, it could be your contract therapy staff, it could be your director of nursing, it could be your nurse manager, or it could be talking to the newest CNA or caregiver. Are we all thinking the same thing when it comes to, is this a safe transfer by using a gait belt? And I'm going to talk to you about some alternative approaches to the gait belt that we at Argent have been observing, that we have talked to various experts throughout the United States about. And we're based out of Wisconsin, and we're very fortunate. We have very large hospital groups and nursing home groups here, and we've talked to them about some of the things that they're thinking about and some of the things that they're doing now when it comes to safe gait belt transfers. And then I want to share with you just some West Bend resources, just to make you aware of some of the resources that you have available to you. So let's start by talking about the benefits and the limitations of a gait belt transfer. So in thinking about a gait belt transfer, utilizing a gait belt for a transfer, what I want you to kind of think about is, if we were all engineering students and we were given the task of designing a tool to help maneuver a person from the bed, let's say, to a wheelchair, what might that tool look like? And, thinking about some of the things you have to do with that tool, and would we come up with the gait belt as envisioned on the left-hand side here, where it's just a strap that is held by a buckle? And if we did, would that engineering professor maybe ask us some questions like, is that tool actually designed for lifting? And if we caught on to what the professor maybe was alluding to, they may even ask us even further, or we may just interject and say, well, we would probably want to design it differently, because if I lift with this belt, it's going to ride up. And that can cause problems, obviously, for the resident, and obviously make it more difficult for the caregiver to lift with. So think about the gait belt and how it's designed. And I put some different gait belts in these pictures. I mean, there's a gait belt in the center that's kind of cool. It's thicker, and you got handles on the outside to grab onto. But still, even if you lift with that gait belt, it's going to ride up. And we're going to talk about a little bit more in depth about, what can possibly that belt do if indeed it does ride up. So looking at the gait belt and the benefits of a gait belt, this is a tool that is widely seen. Every hospital, every clinic, every nursing home, assisted living, maybe in some of your school systems, these have been utilized with their students. So this is a tool that is widely used. It's fairly inexpensive. So some benefits, it's pretty expensive. It's relatively simple to use. I mean, they're, obviously a lot less complex than lifts, right? And some people will even argue it's much quicker to use than a lift and much more efficient. There's no bells and whistles to it. Uh, it gives you something to hold on to. I mean, it's certainly better than having nothing. I mean, if you're going to maneuver somebody and you're trying to just grab onto them, you're going to grab onto the back of their pants or their belt if they have one on, if you don't have one of these. So it does give you something to hold on to, which can be a benefit. And it does help you guide and help you gain some control when you are trying to maneuver your resident. So there definitely are some benefits to what this tool is all about. And of course, there are some limitations to utilizing a gait belt in your facility. Some of the questions you might want to ask yourself is, can injury to the resident occur if not properly used? And we're gonna explore that a little bit further in the presentation today. But if we're not utilizing any tool, but certainly the tools such as a gait belt, we can injure that resident, because we do know that if we're using this tool perhaps as a lifting tool, that it will ride up on your resident and injury can occur. And the outcome of that can be is that perhaps the resident doesn't want to participate in that event or in that transfer because they know it can hurt. Staff can get injured, right? If they're not utilizing this tool correctly, they can get injured, especially if they're using it as a lifting device, right? Because injury can happen either to their back or shoulder, but we know staff can get injured if we're indeed not using this tool correctly. In some instances, and it's been my observations over the last several years, that we can either have a situation where we're overutilizing the gait belt, or in some cases, we're not using the gait belt at all. If we know we're overusing the gait belt, we know we're probably utilizing it as more of a lifting device than what its intended purpose may be. And its intended purpose may just be that this tool is meant to be a guiding tool. It's meant to be something to help stabilize the resident, and maybe not as a lifting tool. And then in cases where we're not using it at all, then what are we going to do if that resident would fall? What are we going to do if that resident starts to lose their balance? What would we have to grab onto? So the question that we're going to be exploring today and really taking a deeper dive and look at is the gait belt actually a transfer tool? There are some experts out there, we're going to discuss this. There are experts out there right now that are stating, a matter of factly, that the gait belt should not be considered as part of your transfer tool or the tool you use to help maneuver your residents. That is something that we're going to explore a little bit today and discuss further as we get into the webinar. So let's ask the question, are staff using gait belts properly? Are they using them the way they're intended to be used on your nursing floors? So when it comes to gait belt safety, what we have to consider is that it's really a partnership. And we really need to consider the residents' safety or residents' maybe capabilities, and the caregivers' capabilities and the caregiver safety. So in many ways, it's a partnership if we're going to use the gait belt as the correct tool to help someone from getting from point A to point B. So what are the injury potentials for a resident, or how can a resident get injured perhaps during a gait belt transfer? When considering the resident's safety with a gait belt transfer, what I want you to think about is if the caregiver lifts with the gait belt, doesn't pull, but actually lifts an upward direction, what does the gait belt do? It rides up. And if the gait belt rides up, can the resident get injured, and what type of injuries what we might see if the gait belt is riding up on that resident's torso. And some of those injuries could be an abrasion. So you're going to probably see maybe a scrape or a red mark or some type of scratch that is going to show that the gait belt actually caused some injury to their skin and to their rib area. You might just see some bruising of maybe where that belt became tight against the torso or against the rib cage, and that area may become very tender. You may notice it when you're helping them with other tasks, and it just might prohibit them if it becomes too sore or that area becomes too sore. It might prohibit them from doing other self-cares, right? Like dressing and bathing and things of that nature. And we could obviously just injure the ribs themselves, especially if the resident you're taking care of is frail. And we could cause, maybe some fractures to that ribs or cause some injury to the rib area, which again can inhibit them in the transfer process. It can inhibit them in their other self-care activities, such as dressing and bathing. So we know that we can be causing some discomfort to that resident. We also know that if we're actually holding and lifting up with that gait belt and it's riding up, that the resident's not bearing the weight that they should be bearing. So the potential for them to need to be lowered to the floor or actually fall to the floor increases quite a bit. What are other entities saying about gait belts then? And I want to make sure that you understand that although I have my observations and thoughts on gait belt use, I want to share with you what some of the experts are out there saying. Two of which are the what's called NIOSH, which is the National Institute of Occupational Safety and Health, and then also the Minnesota Occupational Safety and Health Administration, or Minnesota's OSHA, has come out and made some statements regarding gait belt use for patient transfers. And what they say is that while gait belts are often used by caregivers to assist during patient transfers, they're not designed for lifting patients and are not considered a lifting device. So kind of this helps support, I believe it does help support some of what we're saying right now, is that we want to make sure that the gait belt is used appropriately. And when it's not, and we use it as a lifting device, we have some experts, if you will, saying that we need to reconsider it. It just really should not be used in that capacity. Let's look at staff injury potentials. We've been focusing up to this point on the resident, so let's talk about the staff injury potentials. Anytime you start talking about, staff injury potentials, we want to look at the data, right? So I too here have come up with some data to share with you, and this data comes from actually West Bend insured accounts from our nursing homes, assisted livings, and the hospitals. And the data is about 4 years. We're from January 1st of 2016 to almost the end of October of this current year, 2020. So this data is looking at what injuries have occurred within these facilities. And I apologize for the little bit of blurriness of these slides, but hopefully you can see it. And what this first slide is representing is claims due to safe patient handling. And as is displayed, we have about 1,280 claims over this period of time that have occurred, and these are significantly higher than slip trip falls at 793, and you look at manual material handling at 493. We worry about combative injuries, and that's almost a third at 360. So safe patient handling, the maneuvering of your patients, residents, clients, are causing the most amount of injuries that are happening. When looking at the dollars incurred, safe patient handling claims actually come in second, and not a distant second, but certainly in second, with slip trip falls being at 6.91 million and safe patient handling being at 6.7. If we look at the next category, though, manual material handling, which are lifting claims, not lifting residents, but lifting boxes or things of that nature, is less than half of that. So we are seeing, the significant dollars associated with safe patient handling. When we look at what are causing some of these safe patient handling injuries, more times than not, what we're seeing is that staff is actually manually lifting or maneuvering the individual that they're providing the care for. So what's happening is that we're seeing those back injuries, those shoulder injuries, from lifting and maneuvering the people you serve. What's interesting too is that when these claims are reported, so there was 1,280 claims reported, 240 of them were lost time. So this means that in some cases you're having to lose that caregiver and not be able to tend to the needs of your residents or the clients that you work with. So 241 situations, our homes, our hospitals have had to come up with a way of how do we replace this person, and that cannot be an easy task. That has to be quite stressful, for your directors of nursing, for the nurse management team, or just your facility as a whole, because now you have a situation where you're short-staffed. And then how do you continue to provide that high quality of care that you want to provide for the people you serve? What do we know? What do we know about when it comes to injury, and how the human body maybe becomes injured? What we do know is that there's factors that are involved, and often those factors that are involved consist of lifting heavy objects, uh, maybe like a resident here on the picture to the right. The ladies are trying to boost the resident back into her chair. So we're lifting maybe a heavier object, 100 pounds or more. We may do that repetitively throughout the day. So your care staff is obviously performing many transfers, many different maneuverings of your residents or patients throughout the day. And are we doing these in awkward postures? And we know when we have these three factors that the potential for injury certainly increases. What do we know? We know that injury also occurs if the applied force is greater than the tissue tolerance, and then injury can happen. So the mechanism of injury, and this applies to all injuries, there's three possible prevention strategies to prevent an injury. One would be to decrease that applied force or the stress on the body. So in other words, decrease the amount that the individuals are lifting. The other would be to increase the tissue tolerance or make the body stronger. So we need to make your medical team, your care staff, your caregiver staff stronger, which is certainly an admirable goal, but probably difficult to achieve, and probably not likely to achieve with regards to preventing a workers' compensation claim. Or you could do the combination of both, right? You could lower the amount they're lifting and increase their strength, and that would help too. Again, maybe not always achievable. And this comes from pretty common knowledge. This came out article that I obtained from a certified ergonomist. His name is Ben Kevich. When looking at the potential lifting requirements for a resident, and this would be one resident transfer, and in talking about the fact that our goal really should be is to reduce the amount that your staff is required to lift. Because we know if we can reduce the amount that your staff is required to lift, we know that we can prevent an injury from occurring. So just a very simple kind of demonstration here, illustration of what I'm talking about is if we have a 100-pound resident, and wouldn't that be great if our resident or patients were all 100 pounds? But for simple math purposes, that one resident who weighs 100 pounds, and we transfer them 10 times a day, we could be lifting one caregiver 1,000 pounds during that day. If we work 5 days that week, we could be lifting 5,000 pounds in the week. And if we work for that complete month, we could be lifting 20,000 pounds in a month time. And this would be one one resident. And we can certainly, change the variables. We can say, hey, we only do 5 transfers a day, or we do 20 transfers a day. Hey, our residents on average weigh 150 pounds. So you can change the variables. But the point being is we're lifting a fair amount of weight, or potentially requiring our individuals to lift a fair amount. The goal of safe patient handling and the goal in general is to reduce that amount of weight. And if we can do that, and let's say we can reduce that to 35 pounds, the equation changes quite significantly. So that same resident, we may transfer 10 times a day, but we're reducing that to 350 pounds. And if we work those 5 days a week, that gets reduced down from 5,000 to 1,700 pounds, or 1,750 pounds to be exact. And over a 4-week period of time, or a month, we're reducing that to 7,000 pounds. So oftentimes when I am training my trainers in safe patient handling, I'm asking them, are we thinking about this in the 20,000 pound world? Are we thinking about this in the 7,000 pound world? Just trying to get everyone to think about, are we reducing the amount of force that we're requiring our staff to lift? Because if we can achieve that, we know we can achieve injury prevention. So where does this 35 pounds even come from? It actually comes from research that was done by Thomas Waters, who is a ergonomist, PhD, research safety engineer for occupational safety and health out of Cincinnati, Ohio. And he's wrote many papers and conducted studies on this. But what he's saying at 35 pounds in the studies is that these are under ideal conditions. So if we're having to maneuver someone from off the floor, or if I'm having to reach beyond an outstretched arm, if you will. So I'm reaching far to reach for my resident or patient, or I'm doing this in an awkward position, like I'm twisting, that weight is actually still too much, 35 pounds. So 35 pounds is not the lowest amount. It is the threshold. It's like the limit of what we want people to be lifting. The problem with weight as the criteria for determining a safe transfer or maneuvering of your resident, the issue is that how do they actually know they're lifting 35 pounds? You can't, because the resident or patient, depending on their cooperation level, depending on their ability to bear weight at that point in time. Residents don't have handles, or they're not inanimate objects where we can, like a box, and say that box weighs 50 pounds. Yeah, the resident may weigh 100 pounds, but are they bearing 50% of their weight, 75% of their weight, 20, that can vary throughout the day. So the problem is there's just too many variables. The cooperation of level of the resident, their balance, their weight bearing, as I mentioned, the movement. Do they go right and you want them to go left, and you both end up kind of twisting and turning? So there's too many variables to really say that we can say, well, we're just not going to lift more greater than 35 pounds and we should be good to go. So weight becomes actually, it's an objective term, but it becomes very subjective to apply on that nursing floor. When we look at the weight of the human body, and if we say our resident or patient is 200 pounds, just looking at the percentage of the total body weight, a lower extremity can weigh 37 pounds or more. So we could just be trying to maneuver their leg maybe off the bed or onto the bed, and we could be exceeding that weight. The same thing for the torso. The torso on a 200-pound person person could be 86 pounds or more. So even your 100-pound resident, um, we would be lifting, if it's the torso, more than 43 pounds, or if they just have extremely endeminous lower extremities. Maybe they're only weigh 130 pounds, but their lower extremities may be disproportionately heavier, and we could be exceeding that weight. To help put this all together and help you kind of determine what is the best way to determine a safe transfer for your resident at that given time. And so what Argent has always attempted to do with our various accounts is help them establish some very objective guideline, if you will, uh, methods to determine when should a gait belt be used, when should a mechanical device be used to help safely maneuver your resident. And we always wanted to try to make this as simplistic as possible so that staff is able to recall it quickly. So in this instance, the guideline that we give, so rather than giving, somewhat of an objective term of 35 pounds and say, okay, don't lift beyond 35 pounds. And we already talked about the fact that that's really becomes very difficult to really determine, am I lifting only 35 pounds? How do I know I'm only lifting 35 pounds? So what we have established here is this guideline to help look at, is this transfer I'm about to perform safe or not? So for instance, for a gait belt, what we have said is that if we're going to use a gait belt to maneuver our person we're going to serve, can they bear weight throughout that transfer process? So we're using the gait belt in this instance as a pulling device to help them break that seated plane. You can see in the picture to the right, the caregiver is helping that resident rise from that seated position to a standing position, with the presumption that she, being the resident, is going to be able to bear weight throughout that transfer process. So if we're going from that chair to that bed, they're going to be able to stand, and I'm not going to have to lift them with the gait belt, because we talked about if I lift with the gait belt, what that can do to the resident and what that can possibly do to the caregiver from an injury standpoint, right? There are times, however, that a second caregiver is needed. And what we express is that the second caregiver should not be there to help lift the resident, but the second caregiver should be there as a second pair of hands for that primary caregiver. So, for instance, if we're coming from a toilet or from a commode, and the resident needs assistance with their clothing or assistance with pericare, that second caregiver is there to do that. If they need to maneuver, let's say, that chair because of spatial issues, that second caregiver can be that second pair of hands to maneuver that equipment. The only reason the second caregiver should not be there is because we feel we need to lift the resident or manually maneuver the resident. At that point, that's when we want to look at, do we need a mechanical lift such as a sit-to-stand lift or a toe-to-body lift? So for today's purposes, just looking at the gait belt, we want to make sure that the guideline we want to make sure that your staff is understanding on the floor is that these people need to be able to bear weight and to be able to bear weight throughout that transfer process. So the other consideration for your care staff is discussing that change of status, them meaning the caregiver, recognizing that something is different and I'm about to perform this transfer, but I'm seeing things that are different. And oftentimes I ask caregivers, when I'm doing training with them is, how soon when you walk into that resident's room, do you know that something just is not quite the same? And oftentimes the answer they give me is within the first or second step of walking in that room. So they are truly, the eyes and ears of your facility, and certainly the eyes and ears when it comes to is something not quite right with that resident or patient that they're working with. Is that resident displaying some cognitive issues? Or, I asked them, like, what are you seeing when you notice that? Well, they're not smiling like they did before. They don't wave to me like when I walk in the room or say their usual saying to me. Something just is not the same from a cognitive standpoint. Or maybe they don't notice that, but when they're starting to get them up, they're starting to notice that they just seem maybe a little more fatigued or maybe a little more confused. Or if they're in their chair, they're just not sitting upright as they were before. And something is different, something has changed. They seem unstable in their sitting posture. They get them up to the bedside and the residents sit at the bedside, but now they're noticing that they can't maintain that sitting posture. And if they can't, and I put a gait belt around them and they don't have good seated posture and good trunk control, if I go to maneuver that gait belt, I'm going to probably end up having to lift that torso, right? And if you remember about the torso being 86 pounds for a 200-pound person, well, that 100-pound person, you got 43 pounds you're lifting, a fair amount of weight yet. So, what should that caregiver do in those instances when they are seeing these changes of status, as I'm mentioning? What are you telling your caregivers to do? And what does your policy say? And what have you trained them to do in those instances? And are they starting to question, is a gait belt transfer safe? And if you are doing this, if you can say, yeah, we got this, you know that you have jumped a really good hurdle, and that your facility is doing a great job with making sure the transfers are safe for your resident and also for your care staff. If they're coming up to you and discussing these issues with you, you're winning, and you got to feel pretty darn good about what's happening on your floors. When we look at manual lifting and how it places forces on the spine, there has been studies that have been done on the spine, and they've concluded that about 760 pounds of force the human spine can tolerate. And studies have shown during one-person and two-person gait belt transfers that oftentimes, and this is done on relatively small individuals, that the forces on the spine are exceeding that 764 pounds. And Audrey Nelson and her group down in Tampa, Florida, who do these studies, have basically started to summarize that lifting with a gait belt is unsafe for the caregiver. And they feel that way because they feel that it exceeds the safe limits for the spine. So, and this was done with good body mechanics, bad body mechanics. Body mechanics in and of itself could not change the forces that were on the spine. And many people within Audrey Nelson's study groups and researchers, the safe patient handling folks down in Tampa have said that a gait belt should not be considered a transfer tool. So that's where they're coming from. And these studies have led them to that thought process. Oftentimes we talk about then, as I mentioned before, about body mechanics. And myself being an occupational therapist, I have taught body mechanics for a pretty long time, darn near probably 30 years. And the thought process is if we can place the body in the optimal position, we can reduce the amount of force placed on the body and hopefully prevent injury. Unfortunately, as much as I have always believed that for years and years, unfortunately, there isn't a study out there that shows that that is the case. And, I think back to when I first was teaching this, the number one injury in my facilities that I worked with was back injuries. And we fast forward to almost 2021, and that holds true again today, that back injuries are still the number one injury that occurs in facilities. Not saying that body mechanics and put yourself in optimal position is not something you should not teach. We still want to teach that. It's just not going to be the way to prevent an injury from happening. Because as we're picturing here, if the task, like for instance, these awkward big boxes, just is inherently unsafe, no form of biomechanics can make that job safe. And that's been proven in a lot of studies throughout the years. The American Nursing Association has weighed on this as well, and basically the ANA supports actions and policies that result in the elimination of manual patient handling. So they're saying we got to stop doing the manual lifting and maneuvering of patients if we're going to make it safe for the staff, as well as really the resident themselves. And decades of research show that proper biomechanics, because a lot of times we feel when an injury occurs to a staff member or to a resident that, well, if we would have just performed that lifting technique safer, we could have maybe prevented the situation from injuring people. And unfortunately, there is not any evidence or research evidence that shows that's an accurate statement. Then what does the resident need to do then to make the gait belt transfer safe? A couple of very simple things, right? They have to have the ability to follow some type of verbal or maybe nonverbal instruction because we're asking them to actually perform a task, right? They need to display that good trunk support or be able to sit unsupported. If they're not able to sit unsupported, then think about what does your caregiver staff have to do? They're going to have to support their trunk or their torso during the transfer process, which is going to make them lift. Which is, if it's going to make them lift, we're going to lift up on the gait belt, and all those things can happen with the gait belt riding up. We want them to be able to scoot to the edge of the chair or that seated surface, right? So we start to get their center of gravity shifting forward. If we leave them in back of their chair or in back of the seated surface they're on, we're going to have to lift them up and then over. So we're going to end up having to lift them, even a high functioning resident, if we don't get them to the edge of the chair and kind of get their nose over their toes, we're going to end up lifting them with the gait belt. We want to obviously have them be able to put weight into their legs and to actually perform that standing motion. So we want them to be able to bear weight. And how long do we want them to bear weight? We want them to bear weight throughout their transfer process. So if we're going from bedside to wheelchair, we need them to be able to bear weight throughout that maneuver. If they don't, we're going to have to lift them, or they're going to end up plopping down into the chair, and then injury can happen as well. And ideally, it'd be if they can pivot their feet to their destination. So if they're going from the bedside to the wheelchair, can they turn their feet? Now you can use pivot discs, and I think those can be very effective. But if they can turn their feet and turn towards that destination, that makes the transfer very ideal and safe. And realize the gait belt is a polling device. It's really meant to be a device to guide, but not to lift. So let's talk about the other side of the partnership here, and let's talk about the staff considerations when it comes to conducting a safe gait belt transfer. From a training standpoint, you really want to have agreed upon competencies or agreed upon methods in which you're going to train on the transfer. You want to make sure that all your trainers, whether that's your therapy staff or be maybe a senior CNA staff member, or maybe it's the director of nursing or the assistant director of nursing, whoever those set of individuals are, that we're all training on the same ways, the same techniques, so that there's agreement upon the different disciplines. So when we have the individual caregiver on the floor, they're not questioning how we are actually going about the transfer method. We also want to make sure that there's agreement on how are we determining if a gait belt is going to be safe or not amongst all your disciplines. So that can be obviously nursing, the CNA or caregiver staff, the therapist that gets involved. If you have an MDS coordinator, the MDS coordinator as well, is that all your disciplines within your organization agree on how we're going to determine, is a gait belt transfer the tool to be using? And you can also help reinforce that by doing in-room observations. And these observations really are meant to be unannounced. And what you can be doing with that is knocking on the door of the resident's room or the patient's room and observing, what is staff doing? Are they actually completing the transfer as they were trained? If they are, what a great time to reinforce that. And if they're not, what a better time to reinforce that too, and remind them of the techniques in which they should be using and how this should actually be performed. So let's talk about what we have covered so far, because we have covered quite a bit of ground here, and let's kind of summarize what we learned about caregiver safety when it comes to gait belt transfers and resident safety when it comes to gait belt transfer. For the caregiver, we know that Dr. Waters has said that we should be, looking at how much weight is our care staff actually lifting, and he is suggesting in his studies that we try to reduce that to 35 pounds or less, depending on the conditions. We know that if your caregiver staff is lifting more than their capabilities, that injury could occur. We know, unfortunately, that body mechanics in and of itself can't make a inherently unsafe lift safe. We talked about your policy and your training, and can that caregiver, are we training them to recognize that there's a change of status? And then are we training them what to do when they do see that? Are we allowing them to err on the side of caution if the care plan or ISP says gait belt and the resident's starting to display some things that would make you question that? Can your caregiver staff move towards a mechanical lift to prevent injury to the staff as well as the resident? And that we covered that using a gait belt as a lifting device is inherently unsafe for the caregiver staff. We talked about the study where there's 764 pounds of force is a safe limit, and that study showed that oftentimes was exceeded, that amount of force on the back. So if we're lifting with a gait belt, we know that it can be inherently unsafe, and we saw that, unfortunately, right in the injury data. I always kind of tell my places that are having some transfer injuries, we talk about the fact that we're lifting people, and we need to find a way to minimize that. If we can minimize that, we know that we can decrease that injury potential for the care staff. On the resident side, they have to have the ability to follow verbal or nonverbal instruction. They got to display good trunk support. And I talked about the fact that if they don't display good trunk support, that the caregiver staff is going to end up lifting them. And if we end up lifting them, the gait belt rides up. And we talked about the things that the gait belt can do to the resident if it rides up. They need to be able to scoot to that edge of the chair or that seated surface, right? We need to get their momentum going forward. We need to get their center of gravity going forward, that nose over the toes. Because if we leave them back of the chair, we don't get them maneuvering forward, we're going to end up having to lift them. We want them to be able to place weight into their legs. We want them to be able to stand throughout the transfer process. And we talked about it's advantageous if they can pivot their feet, although there are some tools out there on the marketplace that we can use, like a pivot disc. And that we realize that using the gait belt as a lifting device for a resident might be inherently unsafe. And we talked about, again, some of those injuries that could occur if we if we use that gait belt as a lifting device on your resident. With keeping in mind the safety of your staff as well as the safety of your caregiver, let's look at a potential alternative approach to your gait belt transfers. At Argent, we continue to attend local, regional, and nationwide, countrywide seminars. So for our clients and our nursing homes, our assisted livings, our hospitals, so we can stay on the cutting edge and understand what is trending out there, what are folks doing out there to help keep their residents, their staff safe. And I want to share with you some of the observations and some of the different training techniques that they are out there training their staff on. What I want you to realize is by no means is Argent saying that these alternative techniques are mandatory by any means. And ultimately, it is your home, your organization that needs to determine what is best for your staff and best for your residents and clients that you serve. Please feel free to discuss this with your loss control consultant. I'd be happy to offer some assistance as well with this, but we want to be able to share with you kind of what's new and what's trending. So the big discussion, or a lot of the discussion, is what stance should we be training our staff to be in? Should your staff members, as pictured on the right-hand side, should they be conducting the transfers from the front of the resident or from the side of the resident? And so the discussion is, should we be teaching side gait belt transfers versus that front gait belt transfer? And a number of organizations are looking at eliminating that front gait belt transfer and only conducting the gait belt transfer from the side. So why? Let's go through this a little bit. So the front gait belt transfer, the concern is that it promotes lifting. And you can kind of see in the picture below that she is definitely in a position to lift. And you can almost see where the resident is somewhat, I don't want to say passive, but the resident is kind of like sitting there almost waiting to be lifted. It may decrease that resident's participation. Again, that notion that I'm gonna grab you, I'm gonna lift you up, versus the resident participating in the activity. It can then increase the chances for injury to the resident and caregiver, like we just reviewed, right? Chances of lifting go up higher, and the chances of that gait belt injuring the resident certainly goes up higher. It blocks the resident's view of the destination. So you can almost see where the resident's face is almost hidden a little bit. So they really can't maybe see or detect what we're doing and how we're just about to do it, which can really limit their ability to participate. And it may increase or decreases, in this case, decreases independency. So the side gait belt transfer is what we're trying to do is it promotes really the push, in this case, the pushing motion. You're not really pulling on the gait belt when you're to the side. You're kind of helping that resident break that seated plane. It increases our participation. And if you look the difference between, and these pictures, by the way, were not taken to try to show the difference between a front and gait belt transfer. These were taken 2 separate times, actually. So it was not taken for this, but just in looking at these pictures, you can see on the right-hand side where the resident is much more participating in the transfer than the picture on the left. It decreases the chance of injury because you're not lifting on that gait belt. You're not pulling up on that gait belt. You're not lifting with the gait belt. And the resident, you're able to gauge, is that resident going to stand or not stand? If they're not, you can put them back down and go get a lift, right? It allows the residents to see their destination. So you're not blocking their view. You're not kind of like taking up their space. You're actually opening up the space for them to maneuver. And hopefully what that's then doing is increasing their independence, that they're the ones that are doing it. You're there just to make sure that it's done safely, you being the caregiver. So just some other pictures here. So you can see, here the caregiver is on the left-hand side picture. The caregiver is to the side. She has her hand on the gait belt. She's steadying the walker for the individual. You can see where the residents, has nose over toes. They have full ability now to stand. Where here you can almost see where she's somewhat, although she's participating really well on the right hand side picture. She's participating. The residents participating extremely well. But again, we're blocking her destination. We're blocking her view, and we're still like in a position. Okay, I'm not standing till you lift me, as maybe a thought process. And then just looking at the side gait belt transfer a little bit in its progression. So you can see again on the left-hand side where the resident is pushing off the bed. She's getting her nose over her toes. That walker too is just right there for her. Although we never want her to grab that walker because it's unstable. She has that a little bit of security with that walker being there, because that will be something that she can maybe bring herself up to a more standing position and feel a little safer. And then you can see on the right hand side, if you're doing some ambulation, how you're automatically in a great position as a caregiver to do that ambulation with that resident. I would like to make you aware then of some of the safe resident handling resources that Argent has available for you. Argent has many safe resident handling resource materials, or what we call client use materials. We have, and I'm part of the committee, we have a healthcare advisory committee where our sole objective is to develop materials that can help you with your safe resident handling programs. We've expanded that now to actually looking at how can we prevent combative injuries. We have materials on how to prevent needle stick injuries. But for today's purposes, I just highlighted some of the materials that we have available for you. I would also ask you that when you speak to your loss control consultant, if you have some materials you would like for us to produce, to let them know, and then we can consider developing those for you as part of the SAFE, or in this case, the Healthcare Advisory Committee. So some of the materials that I highlighted for today's discussion is we do have a program audit guide. And this guide was developed to help you look at your safe resident handling program and identify what are some of the strengths of your program, and also then what are some opportunities to help you enhance them. You can utilize this as a self-assessment tool, or you could ask your loss control consultant at Argent to assist you with that, and they'd be happy to do that. The other thing is we do have sample, what we call safe patient handling policy worksheets. And we have two separate policies for you to consider. One is that displays using the side gait belt transfer only, and help support kind of what we're discussing today about that. And the other one is more traditional safe patient handling policy that includes not only the side gait belt transfer, but also includes the traditional front gait belt transfer. Argent has additional training materials, and we call them our supplemental materials. And these are actually our training videos that we provide for our accounts. So once you have your policy in place and you have the equipment in place and you have your trainers identified, we can help you develop your actual training program. And these are a video series of some of the key components of your safe resident handling program or safe patient handling program. The nice thing about if you determine you want to utilize these videos for your training is no matter who is providing the training and if they're following the videos, you're going to have a uniform message or a consistent message that your staff is hearing. And that can help make sure that we have that consistency on the floors as far as how we want them to perform a gait belt transfer, how we want them to maneuver a resident in bed, for instance. So the consistency can be a real advantage for you. And your Argent loss control consultant is able to take you and your trainers through these videos so they can clearly see how they're utilized, and they can ask questions of our consultants and help you through really developing a formalized approach to your training programs. So in summary, gait belt safety needs to encompass the resident and caregiver's capabilities. We need to make sure that for the caregiver that it doesn't exceed their capabilities, right? Their lifting capabilities, their maneuvering capabilities, and also then for a gait belt for the resident, they have to have the ability to bear weight, hopefully bear weight throughout the transfer process, and display the ability to complete that transfer safely. Gait belt is a non-lifting tool. It's really not meant to be a lifting tool. And when we do use it as a lifting tool, we could place our resident in a position to get injured as well as your care staff. Organizations are trending towards the elimination of that front gait belt transfer. Again, another step towards reducing the possibility of actually lifting with that gait belt. And a lot of places are starting to look at, should we be just using the gait belt as a side gait belt transfer and not from the front. And Argent's loss control consultant staff and the healthcare advisory team are here to help you and help you enhance your programs, whether it's your policies, whether it's your training, however we can help you reduce this risk and exposure. So I want to thank you for listening in today. And if there are any questions, we certainly will be able to stick around and answer any questions you might have. And I do appreciate you taking time out of your day to listen to this webinar. Thank you.